So here I'm going to share my experience to how to use a cost-effective strategy to implement the transperineal biopsy. And thanks, Dr. George again, and with the music team when I was research fellow in Michigan. So we all know about the transperineal has a lot of benefits, infections, sepsis, antibiotic storage, but the most concern we are going to do when we are doing the transperineal biopsy. However, the cost for the additional equipment has cost a lot. So there are a study we launched back to the Michigan. There we study about how to lower the barrier to do the transperineal biopsy. And there are only less than 10% institution do transperineal back to 2021. And the 70% of the provider said the major barrier is about the access to the equipment. So when I back to Taiwan, I faced the same situation. And just for your information, the reimbursement for one prostate biopsy in Taiwan is only $50. So there is no way we buy a fancy or very good equipment to do the transperineal biopsy. So as we know, there are two critical equipment to do transperineal biopsy. One is the linear convex probe. When we do in office, we usually use the convex array probe. So I have no linear probe, so I only use the convex one. And about the device for alignment, we have seen a lot of like the pivot from the cervical yesterday morning, and like great, but they all cost. So we don't need to do that with the alignment equipment. So here is how I do it. About the preparation, this is what I did. I used the biopsy gun, the probe, convex one, and this is the Sapphire like guide cannula. It was like here. So I separated from the probe to do as a skin puncture site. I do a skin puncture and put this cannula like 1 centimeter inside to avoid like several puncture on the skin. And I use a spinal needle to do the anesthesia. So surgical position is just basically lithotomy position. And I do local anesthesia, and sometimes I combine with the general sedation. So the size where I inject is basically based on the patient's body size and the prostate size. So I do the skin, and then I do the track anesthesia. I didn't do the nerve block. I only do the anesthesia between the prostate and skin. So both sides. So when I do the injection of the lidocaine, I will avoid the urethra, and I push the needle into when I touch the prostate capsule. And after the needle touch the capsule, I will inject the lidocaine inside. So as you can see here, this black area is where I inject the lidocaine. So use this method, I can approach to like every zone of the prostate by only single puncture. But the tricky part is here when we use the linear array, the needle comes inside horizontally, very like straightforward. But when you do the convex one, as you can see, I put the needle horizontally, but it turns out to be like a little bit steep here. So what we have to overcome is you have to imagine where your needle will go. So this is a learning curve to do with the convex array. So we can do like horizontally, and we can get the posterior proportion. And when we make some ambulation, we can get the anterior portion of the prostate. So you can, as you can see, this is a bit angle up and get the anterior portion of the prostate. And when we do more horizontally, as you can see the different color line, we can get the different part of the prostate. So I use the music template. I do 5 chords on peripheral zone and 1 chorus in the transitional zone, both sides. And here is the pictures where I do the prostate biopsy. So this all without alignment, we can still has a very good view to see the prostate and get the needle punch inside the prostate. So we also published our initial work last year. So this is 1-year data, and all the transperineal biopsies done by me, and the other surgeons still do the transrectal biopsy. So you can see the PSA level. My group is a little bit lower, and the others are a bit higher. And some patient, I do the cognitive fusion biopsy, so I did MRI before. But looking at the systemic biopsy cancer detection rate, I do fusion plus the systemic. So the detection rate between the two groups are similar, is around 45%. And I think the prophylactic antibiotics, because this is the first year, I don't want anything goes wrong. So I did give a single shot of cephalosporin before the surgery. But for the others, our standard of care is give levofloxacin for at least 1 week. Some physician will give 2 weeks. So I do also local anesthesia, sometimes with sedation. So the other groups, when we do the transrectal biopsy, we don't do any like nerve block or something else. We just use the lidocaine jelly with lubrication. So the complication rate, there is only one has significant difference, which is hematuria. But when we look at the data about, the data about the infection, there are 0 patients get any infection, while the transrectal still got some, even they gave a quinolone for 1 week. So my conclusion is that TP biopsy has benefit in infection complications. We all know that, and TP biopsy can be costly because additional equipment like a probe, like the alignment system. Doing freehand TP biopsy with original set is reproducible without additional cost. What I didn't mention in this slide, I think is patient's satisfaction. So when I when I doing the transrectal biopsy, when I ask patient to do the repeat biopsy for active surveillance, they usually say no. But after I do the transperineal biopsy, patient like they say it's not big deal, and they accept to do the repeat biopsy right now. So I don't do the study on the like PAN score or something else, but for my personal experience, they adapt this method more, but it's only my experience. And thank you.